This is Hubwonk. I'm Joe Selvaggi. Welcome to Hubwonk, a podcast of Pioneer Institute, a think tank in Boston. 2 years after identifying the COVID-19 virus, the public and our policymakers are still struggling to understand who and for how long a COVID patient must isolate. A recent CDC recommendation of 5 days of isolation before returning to daily routines with no additional COVID tests seems to ignore both the reality that the disease behaves differently in each individual and the power of a simple test to deem someone safe to leave isolation. If our goal is to reduce the spread of COVID, could we better use the tests available to ensure those who are contagious remain in isolation? My guest today is Hannah Mamuszka, CEO of Alva10 and precision medicine expert. As an advocate of precision medicine, Hannah has been a clear voice in explaining the value of abundant, accurate tests that indicate who is contagious and when. Hannah will explain the reasons for confusion around testing, which tests are for which purpose, and what our listeners can do with the results to better ensure their own safety and the safety of their community. When I return, I'll be joined by precision medicine expert Hannah Mamuszka. Okay, we're back. This is Hubwonk. I'm Joe Selvaggi, and I'm now joined by Alva10 CEO and precision medicine expert Hannah Mamuszka. Welcome back to Hubwonk, Hannah.
Thank you so much for having me, Joe.
Well, it's great to have you. And now we're coming up on, unfortunately, the second year of this COVID-19 pandemic, or endemic as it's being called now. I'd like to talk about how to mitigate risks, how to test, perhaps what best path to go if we test positive. But let's start at the very beginning. You have been a guest on the show in the past. This is a virus that started in, we call it COVID-19 because it started in 2019 and originated in Wuhan, China. We're now with a few new variants down the road. How is this a virus emerged, and how are these variants, how much different is the newest variant from the original?
Well, this variant is really interesting. It has a lot of mutations in it, which is not uncommon for viruses. Viruses mutate all the time. They mutate basically every time they replicate. So they replicate millions of times a day. So it's not surprising that we're seeing different variants with a lot of mutations, but the Omicron variant is pretty unique in the number of mutations it has. And for reasons that we don't yet quite understand, the mutations have caused it to be able to be more transmissible more quickly, which essentially means that it takes fewer copies of the virus for you to have in your body for you to start transmitting the virus to other people. Fortunately, the structure of the virus and the proteins on the outside of the virus are still basically the same, which is good because it means that the vaccines are still very effective, and the diagnostic tests that we have, both PCR and antigen, still work quite well to detect the virus. A function of the diagnostic testing, of course, is how much virus do you actually have? And I think that's really the part that has changed with Omicron, is that you start having symptoms with a much lower amount of virus than in previous variants.
Now, you're an expert in precision medicine. I'm going to ask you this question out of the blue. Is there any way, I know that I take PCR tests and antigen tests. I have no idea which variant I might have. I've always been negative, but how would I know? And how do my fellow citizens in a population, how do we know which variant we have and which is in our population?
So this is being studied more at the population health level within certain cities and certain states. Candidly, we in the US have not done a great job of this. Most of the health systems in other parts of the world have done a much better job of continuously studying for mutations in different variants. Our current PCR tests, though, are able to distinguish between Omicron and Delta and some of the other variants. Most of this work, though, is being done using deep sequencing to really tell both what the prevalence of the different variants is in a population, and also to really track for new variants to see if any that are popping up that are going to be problematic either now or in the coming months.
So scientists take, let's say, somewhat random samples and use that to infer from that the population spread and which variants we have.
Right.
As these variants have emerged, you've already answered my question, but we're still confident that the vaccines that, for our listeners who listen, follow the show, we are strongly in favor of getting all the vaccines and your booster. But are these new variants, particularly Omicron, are the vaccines still effective in both preventing to some degree and reducing the symptoms and risks of Omicron?
Absolutely. I mean, these vaccines are amazing. We are truly lucky to be living in a time where vaccines that are this efficacious can be developed and deployed in the way that they've been. I think we have to kind of go back to remember how viruses work in order to think about what is actually happening and what does it mean for a vaccine to be working versus not working. So when you get exposed to a virus, what the virus needs to do is it needs to get into your cells to infect them, because viruses can't divide on their own. They're not bacteria, they're not fungi. They need a host to find, and you're the host that they want to find. So they want to find a way to get into your cells to replicate. And if you haven't been exposed to a pathogen before, you'd be considered naive. And the virus would potentially have a chance to really start replicating very rapidly before your immune system recognizes that it is a foreign agent and it needs to be removed. The removal of those foreign agents are when you have symptoms. That's when you develop a fever, because pathogens generally don't like high temperatures. So your body tends to try to cook it out. You may develop mucus, which is a way of your body trying to excrete pathogens out of your body. Those are the symptoms that you feel. When you have a vaccine, when you've been vaccinated against something, your body already knows what the pathogen looks like. So even with Omicron, which is generating symptoms in patients a lot quicker than the earlier versions, your immune system is much more ready than it would have been. And what this is preventing is most patients from developing long, more serious symptoms, from ending up in the ICU as a result of those symptoms. And that is incredibly important for where we are with how many patients are getting Omicron right now.
So I want if our listeners take nothing away from our conversation, I want it to be that they better understand the concept of testing. I come to this question because as much as an advocate as we are, certainly you are, of testing, I've had people say, look, I've heard this whole testing spiel. It doesn't help me at all. So if we take nothing away, I want to make sure our listeners understand the difference in tests, what they're useful for, what they detect, and when they should be taking them. So let's start at the beginning. You mentioned at the top of the show the two tests, the PCR, which is looking for antibodies, and the rapid flow, lateral flow tests, which are looking for antigens. Let's start at the beginning, because I think most people are familiar with PCRs. Those are the things we lined up in traffic and got our nose swabbed and got a result 2 days later. What is that detecting in our bodies?
Sure. So one slight correction. PCR is actually detecting the genetic material of the test. So PCR tests, they're all amplified tests. So you're basically taking a really small amount of material and replicating it a number of times, like thousands and thousands of times, until you have enough to determine if it's actually present or not. The laboratory PCR tests that you go and you wait in line for, and then they take, a couple days to get the results back to you, are the most sensitive tests. They are detecting very, very small amounts of viral particles in your body. Detecting those viral particles, though, doesn't really tell you if you're actually infectious or not. You could be infectious. You could be pre-infectious, which is a very small period of time when you've been exposed to a virus, but you maybe haven't started to show symptoms. Or most likely, you could be post-infectious. The post-infectious period is the period of time after your symptoms are resolved, when you're no longer contagious, but when you would be positive by PCR. And you'd be positive by PCR because the PCR machines are so sensitive that it can still detect the little bits of viral fragments that are going to be found within your body. And that is interesting from an academic perspective, but it's not particularly helpful. It doesn't tell you if you should be able to go to work. It doesn't tell you if you're infectious or not. It's interesting, and it's definitely something that we should be tracking, because we want to understand the prevalence of COVID within our populations, but it's not particularly helpful. There are also the rapid PCR tests, which are the PCR tests that you can get at maybe your local pharmacy, where you go in and you get a phone call in a couple of hours. Those use a amplification technology called LAMP. It's a bit less sensitive than the lab PCR tests. It's still PCR in that it still amplifies the signals. So you still have the question of, is there actually enough virus in here for me to be infectious? And then the last type of test that I think everyone is trying to find online, trying to find on, Walmart.com, are the antigen tests. And those are the tests that actually detect the viral protein. And what's different from the PCR tests and the antigen tests is that PCR tests are amplified, whereas antigen tests are not. And so you have to have a fairly substantial amount of virus in the sample for an antigen test to be positive. And that positivity on an antigen test directly correlates with you being contagious. And that, I think, is really the question that we want to know. Are you contagious today? Can you go to school? Can you go to work? Can you travel? Can you go see a show? And those are the most important questions that we need to answer, because we really want the people who are contagious to stay home and isolate and try not to infect anyone else. Whereas the people who may have had COVID 2 months ago, but are still PCR positive, we don't want to keep those people out of school and out of work.
So I think what you said is pure gold, and I want to emphasize and repeat what, the important parts. Were I to say, for instance, be able to have the luxury of having a PCR test every day of my life, and I get exposed to COVID, and that PCR test will, from the moment my body recognizes the COVID, through the process of being sick and very contagious, post-COVID, I'm no longer contagious, but I'm recovered. I feel great. For months afterwards, my PCR test would test positive, and therefore it doesn't differentiate between the phase of the disease where I can infect others and that phase where it's more or less benign. My body's gotten past it. That's the PCR test, and that rightly doesn't give us much useful information, actionable information. By contrast, the antigen test, lateral flow test, the one that we've been giving out in Boston for free, really, or that we can get at CVS. That's telling us the real valuable information. That's saying you are contagious to others at this moment. And if it tests positive, you had better isolate and not participate. And until it tests negative, you ought to remain in isolation. Do I have that about right?
Yeah, absolutely. And I think a lot of us in the diagnostics industry have been calling for better access, particularly for the antigen tests, for months, and frankly, almost years, because that is really the information that we want. You can be PCR positive and never be contagious. You can never be, you may never have symptoms. We know part of the problem with COVID is that a lot of people haven't realized when they have had the virus, they may have had it already. But knowing if you're contagious, knowing if you are able to infect others is really the key to stopping the spread.
So what puzzles me, and this is a moment in time. We've just had a CDC recommendation handed down that says, look, if you do test positive, and I'm assuming they mean antigen test, that you should isolate for 5 days and then go back to your life. We know that, or we should know that COVID is contagious for in the ballpark of 5 days for the average person, but it can be less or more. Does that seem wise to send someone back merely because 5 days have passed since their positive test? Or might it be wiser to suggest they, in addition to waiting 5 days, look for a negative antigen test?
Yeah, this is a recommendation that I really don't understand, because the average is 5 days, but that means that that's in the middle. A lot of people are not contagious at day 3, and a lot of people are contagious at day 8. And so when you pick day 5 and say, as long as your symptoms are resolving, you can go back to work or you can go back to school, symptoms and being contagious are not actually connected. The symptoms that you have are a reflection of what your immune system is doing and your immune system's ability to clear the virus from your body. That is actually distinct from the amount of virus you have in your body, which is related to how contagious you are. And that's what the antigen tests pick up. And I'm really hoping that there will be additional guidance that comes out that really describes that and really emphasizes to people, particularly people who have to be in a face-to-face job or in school where they're interacting with other people, that after you have waited 5 days to really take an antigen test and make sure that you're not contagious before you go back out into the world.
Because you may be one of those people who test, or for whom they are positive for more than 5 days or contagious for more than 5 days. You want to be sure that you're not, and you'd be confident if you tested negative on an antigen test, that you should be somewhat confident that you're no longer contagious.
Particularly if you've tested positive before, the antigen tests are remarkably good at distinguishing when a patient is contagious or not contagious. But this messaging really needs to change on the national level. There are a lot of employers right now that are requiring PCR tests for return to work, or are not accepting antigen tests as proof of why someone should not be coming to work. And what that's creating is a labor force that is either being forced to work or not enabled to go back to work, because the PCR test is still positive, or because the antigen test isn't accepted. So we really need better messaging to really explain the differences in what the tests are testing for and how they should be used to make healthcare, employment, and education decisions.
Right, indeed. Coming back to your earlier point, were we to use PCR as our test for how contagious one is, you might be out for 3 months unnecessarily.
Right. I mean, my school system, where my kids go to school, if you've tested positive by PCR, you're not allowed to participate in the pool testing for 3 months for that exact reason, because you could continuously continue to show positive when you're actually not infectious.
All right, this is actionable information. It's very, very good. So let's imagine now we've done all our tests. Our audience is on tenterhooks, and we've been taught that COVID is not likely to be serious, but could be very serious. They've taken their lateral flow test, and they get that second line, and they're filled with dread. Right? What would you say to our listeners who test positive for COVID? What should be their reaction? Should as we've heard, some people rush to the hospital? Should we immediately call our primary care? What would be a sensible, informed reaction to a positive test?
Well, first, I do think calling your primary care physician is important, because we need to know who actually has COVID. We need to understand the prevalence. And so I think the beauty of the at-home test is that you can do it at home and you don't need to go and wait in line somewhere. But I think we're missing a lot of people who do test positive because they're not being tracked by the healthcare system. But I don't think it's helpful for people who test positive at home and have mild symptoms, to be going to the hospitals for a confirmatory PCR test. Our hospitals are really backed up right now with COVID and a lot of other things. And you can be confident, if you're positive on your at-home test, that your test result is accurate, and that you should begin your isolation process. In terms of symptoms, I'm not a physician, and I don't want to pretend to be one. But a lot of the guidance shows to track both your fever, and perhaps looking into purchasing a pulse oximeter to track your respiration.
I see. Now, when we do test positive, are there any rules of thumb that can tell us, are we at higher risk of a severe COVID than others? We've heard certainly age is correlated with that. That's been well understood, that age is highly correlated with severity of disease. Are there other characteristics that would put us in the high probability of bad outcomes?
Yes, the number one thing behind age is obesity. And we have, of course, an obesity epidemic in the US. 42% of adults in the US were declared as obese as of January 2021. So that's a lot of us. And I think that the messaging around what actually qualifies as a comorbidity has been a little confused, because there has been eh, eh, physicians are often reticent to talk about overweight and obesity as being a risk factor in and of itself. But I think it's important to understand that being over an ideal body weight is a risk factor for ending up in the hospital with COVID.
Hannah, we don't want to disparage people who are obese or have a higher BMI than is recommended or healthy. But what is the mechanism by which being obese makes us at greater risk? Again, I'm sure it's a greater risk of other diseases as well, but what's the mechanism by which an obese person might be more vulnerable to this disease than others?
Yeah, that's a great question. And I mean, first of all, I really wish we could talk about obesity like we talk about other diseases, and not talk about it in a disparaging way, but we haven't been able to do that recently in the US. Part of the problem with obesity is an increase in inflammatory signaling that kind of confuses your immune system. It's sort of like if you're in a hospital or in an environment where an alarm is continuously going off. And at first you pay a lot of attention to it, but then it just kind of gets numbed into the background. Uh, fat cells have their own inflammatory signaling. And there's a school of thought that it actually makes it more difficult for the immune system to recognize quickly a new pathogen coming in and respond to it. And then what happens is that because the response may be a bit slower, the immune system then overcompensates, and you get kind of this classic syndrome of symptoms of overreaction, overcompensation of the immune system. And that in a lot of cases is actually what ends people up in the ICU and really struggling in the hospital, because their immune system has overcompensated for the presence of the virus. And it's not so much the presence of the virus, but it's that inability to appropriately respond that is problematic.
So we've talked about testing, and we've talked about those who are more likely to get serious outcomes. When we arrive at the hospital, does any of your research look at what therapies are out there and the success rate of someone who has all, they're sick, they are predisposed to worse outcomes? What can be done once they arrive at the hospital?
Well, again, and I'm not a physician, but there are a number of new antiviral therapies that are working really well. The key, however, in them working really well is that they need to be used within the first 3 days of onset of symptoms, which means you need to be able to have access to a diagnostic test that tells you what your disease is, that confirms that it's COVID, and then getting access to the therapeutics. And that seems pretty basic. But if you've tried to get a test and you've tried to get an appointment with your physician in the past couple of months, those are actually really difficult to do. And that's why so many people are going to the hospital to try to get the new antiviral therapeutics. But the key to them being effective is really making sure that they get used as quickly as possible after diagnosis, particularly for a high risk. There was one other point, though, that I wanted to make when you mentioned high risk, because there's actually another population within our society that we're not really thinking about because we don't really understand. And that is the fact that, and we've all heard these anecdotes of someone who doesn't have any comorbidities, doesn't have any other risk factors, but still has a really poor outcome with COVID. And there's data out there generated by a number of diagnostic companies as well as several academic labs that shows that some people have a higher genetic risk, genetic susceptibility to COVID, to ending up in the ICU. And that's another diagnostic test that would be really valuable for us to have, to be able to understand what your personal risk of having a poor outcome with COVID would be. But unfortunately, these tests have not yet been commercialized for the reasons we've discussed on the podcast previously.
Of course. Now, that's very exciting. Again, I want to I was going to ask that question a bit later, but let me go a little bit deeper. I'd heard early in the pandemic that even things like blood type might give away your risk factor, that if you're A type blood, you're more risk than O type blood. Is this the kind of thing we're looking at? And if such tests were possible, as you say, it's being developed, would it indicate our susceptibility to COVID or to all disease? How much could these brave new tests offer us when we get the result?
So the data I've looked at has specifically been looking at COVID-19, or specifically looking at the SARS-CoV-2 virus and the implications for the COVID-19 disease. And it's interesting because part of it is looking at, why do certain people's immune systems respond so quickly, or you never become infectious, versus some people end up getting so sick so quickly in a way that wouldn't be able to be predictable. The reason that we're in a pandemic is because this virus is so distinct from other pathogens that we encounter on a daily basis. I mean, by the time you're in your 40s or 50s, you've been exposed to thousands of pathogens, viruses, bacteria, fungi, the majority of which don't make you sick, the majority of which you don't have an inappropriate immune reaction to. But this one is different for some of us for some reason that needs to be understood.
All right, let's talk about your field of precision medicine. And I'm trying desperately to find a silver lining of this terrible COVID pandemic. You've been on the show before, and we've talked about the importance of precision medicine and the fact that testing. Has this pandemic, both from the medical community and the policy community, has it opened our eyes to the value of testing and the fact that given limited resources, that we could be doing better with our systems if we were to spend more on, as you mentioned, prevention and testing, and less on people who come into the hospital already sick?
Yeah, absolutely. I really hope that this has changed the thinking. In the US healthcare system is built on an actuarial model. So insurance companies, and for the large part Medicare, look at things on a year-over-year basis. And when you make decisions on a year-over-year basis, you devalue things like early diagnosis, risk stratification, and generally public health, because you don't see those benefits in a year's time. But we really need to think about what we want to have available for the next pandemic. Part of the reason that we didn't have, and we still don't have, the diagnostic tools that we need is because we haven't built the infrastructure to be able to have them. We haven't built the financial infrastructure to invest in them. We don't value the patents for diagnostic tools. We don't value the machinery, the information that comes out of them. And we have to change this. We have to, if you blow this out across disease areas, we need better ways of diagnosing disease. We don't have an accurate diagnostic tool right now for Alzheimer's disease, for example, which is on everyone's mind, but most people don't realize that we actually diagnose Alzheimer's disease largely by ruling out everything else and then diagnosing the patient as having probable Alzheimer's disease. We don't have a ready diagnostic for NASH, which is a liver disease that actually affects about 12% of Americans and is the #1 cause for liver transplant and liver cancer. But we don't have a diagnostic that's easily available that actually diagnoses NASH. What I really hope is that through the COVID pandemic, it will help us realize that we need to value the information that we get from diagnostic tools up front, that we need to reconsider how we value from an economic perspective and maybe redo our actuarial model of how we pay for healthcare. We're very happy to pay for drugs and procedures and hospitalizations because they happen right now. But the value of a diagnostic tool may not be seen this year or this quarter. And so we haven't really built an infrastructure that allows us to invest and develop tools for when we need them.
Now, we here at HubWonk, we're proudly market fundamentalists, so we believe in incentives and aligning incentives to get the right outcomes. We both agree that diagnostic or greater emphasis on diagnostics would help. At what level, if we want to move from an actuarial model to something better, whereby we reward systems for preventing disease as much as we do for treating disease, where does that come from? From CDC, FDA, from insurance companies, from hospitals, from who will help us realign and better value the tests that will protect us in the next pandemic?
It's a long chain, but I think it does have to start I think it has to start on the government side. That's where a lot of the research comes out from. That's where also a lot of the original structures around payment for novel diagnostics come from. They come from the Medicare system. And so we need to start from that perspective. We need to have a system that creates a way to pay, a way that the government will subsidize and sponsor and value research and development and manufacturing in the same way that we have for therapeutics and vaccines. And then we need to figure out a way to carry it all the way through. And maybe that means we need a new way of paying for healthcare. In addition to health insurance, there are companies that are working on digital models where, you are able to carry a certain amount of monetary value with you when you change health insurance companies. And that would allow value to attribute between companies for a novel diagnostic that would allow you to improve economics of the healthcare system.
So we're coming to the end of the show, and I wanted to cover, at least I hinted at mentioning this in my earlier question, but let's imagine 5 years hence when COVID is a distant memory. Let's hope that is the case, or it's so endemic that it doesn't bother any of us. And there's some new horrible disease that comes out of some far off land. In this better world, would you imagine that we would all have the ability to test immediately so that we know the extent to which the disease is with us, and sick people get treated and well people, don't, and we sort of headed off at the pass rather than sort of this muddled mess we've had over the last 2 years? Is that what you would imagine? Each of us would have some sort of easy access to diagnostic tests immediately?
That's what we hope for. And I think that now, 2 years into the pandemic, I think people will demand it. Most people didn't know that they should be demanding antigen tests in March, May, June of 2020. But now they do know. Now they know that it is possible to have a test delivered to your house and you to diagnose based on the results of that test. Then you don't have to go wait somewhere. I think educating the populace will create a demand that we haven't had before. And not that, and I think that we should think about the fact that there could be more severe pathogens that come to us with even more significant consequences, and we should be ready with a diagnostic infrastructure to support that.
That's great advice for the policy folks in our audience. Let's get hot on making sure we have diagnostics and be ready for the next disease, which is somewhat inevitable, I suppose. But that's great information, and I'm glad we've been able to clear up quite a bit of misinformation. I think largely engendered by the fact that the PCR test, I think, was the wrong test for the wrong time, and it's got enough people confused that now I think we're on the right track. We've got, I think, somewhat abundant access to antigen tests, and as you say, that demand will sort of continue into the future. Thank you very much, Hannah, for joining the show. You've, I think, given a lot to our listeners.
Thank you so much for having me, Joe.
This has been another episode of HubWonk, a podcast of Pioneer Institute, a think tank in Boston. If you enjoyed today's show, there are several ways to support us. It would be easier for you and better for us if you subscribe to HubWonk on your iTunes podcatcher. If you'd like to make it easier for others to find HubWonk, it would be great if you would offer us a 5-star rating or a favorable review. It's always welcome if you want to share HubWonk with friends. If you have ideas or suggestions or comments about future episode topics, you're welcome to email me at hubwonk@pioneerinstitute.org. Please join me next week for a new episode of HubWonk.